Κύριε Βελή.
Ευχαριστώ πολύ. I'm sorry to address the audience in English because of the technical nature of the talk. I would have great difficulty in keeping in conjunction with the time to the appropriate expression of what I would like to say. So with the apologies, I would continue to, let's see, how does this work? To acknowledge the support that I have received for coming to this conference, and this is the only thing that I will have to disclose. In terms of the topics to be covered, we will have to deal with a number of issues here that I hope that will be addressed in the coming half hour. And you can see the structure of my talk in those slides, and I will finish with the recommendations for ancillary studies and a preview of coming attractions soon in this theater, if all goes well. So the different approaches in the pharmacoresistance of epilepsy are, in a nutshell, the neurologist's approach, which most of you know very well, the appropriate choice of medication, the neurosurgeon's approach, which is taking out what can be taken out, because the only thing that heals is cold steel in the eyes of the neurosurgeon, and the neuromodulator's approach, where you try to preserve function and structure but address the issue of controlling of seizures where pills and surgery fail or are not in order in case of surgery. So the use of electric current to abort seizures is something which some of our colleagues here in Athens have addressed in the course of time. I refer to recent publication 2014 on the torpedo effect in medicine, which is based on the experience of Greek philosophers with electricity and also the experience of military physicians in the service of the Roman legions like Dioscorides, who reported to have used this in epilepsy. Galen said that if you give the shock, then you might as well eat the fish because the cartilage is good for the epileptic boy. I will not touch on this though. Moving to a more recent times, the external application of epileptic current in epilepsy is quite well established, and it goes hand in hand with the identification of the homunculus, which the previous speaker alluded to, the corticography studies that were performed in the 1950s and 60s by Penfield, corroborated with the EEG studies of Jasper at the same time. The studies of Cooper and others in the 1970s, where cerebellar stimulation has been carried out. The ones of Velasco and Velasco, two brothers and a niece from Mexico, that primarily address the hippocampus, but also the anterior nucleus of the thalamus, also the centromedial nucleus. Uthman and others with the VNS that we know very well. Lozano and others with thalamic nuclei. A variety of nuclei have been targeted, and those reports in the literature have the common characteristic. They're fragmentary. They're usually lacking statistical power, and they might have some problems in replication. So we will not discuss this because they're also not closed-loop stimulation. I will stand here on an evidence of the application of stimulation in the EEG. Here, as you can see, the stimulus is being applied externally during an epileptic discharge, and that stimulus ends that discharge according to the authors of that paper. Sometimes Osorio and others needed repeated stimulations, which you can see here, in order for them to suppress an epileptiform discharge on the EEG. The flat line that you see here is the result of the amplifiers that are being blocked, because otherwise they would be saturated by the stimulation. So we know that electrical current is able to arrest epileptiform activity in the EEG, and so that has led to an editorial by Lesser and Theodore in Neurology in 2006, after many years of application of intracranial electrical current, if not pharmacology, maybe physics, because physics might help us in understanding how this works. The next slide will indicate to you that not only one train of pulses in time saves 9, but also a single pulse, and this is from work that we have published a number of years back in the Journal of Clinical Neurophysiology, where in a simulated seizure, if you appropriately choose the phase at which time you give a stimulus, a single stimulus, if correlated to the phase of the discharge, will stop the discharge. Again, this is in silico work. It's not in vitro, and it's not in vivo, as you can see. But this application has been also carried out in a number of studies in humans. And here you see some work from Centeno and others in Neurology 2006, where you can see how hippocampal stimulation will work. Those are the same electrodes that are being used for deep brain stimulation in extrapyramidal disorders. They consist of 4 channels, and essentially the stimulation that is being applied is the same that's derived from the deep brain stimulation studies in extrapyramidal disorders, where the hippocampus is penetrated as a skewer from posterior to anterior. You have 4 contacts through which you can give electrical current. Now, the first truly randomized controlled double-blinded study carried out in a substantial number of patients in refractory epilepsy has been the one that's codified as SANTE, the study of the anterior nucleus of the thalamus stimulation, with a very impressive number of colleagues, and it was carried out in North America a number of years back. The publication is in Epilepsia in 2010, as you can see. And that was a study that included 157 patients that signed consent, and finally 91 patients remained in the study. The patients completed a baseline measurement, which is based on a calendar estimation of their seizures. They were implanted. They completed the blinded phase. There was an error log term correction. Some discontinued it. 2 years and 25 months later, 102 remained in this, and 91 completed the study. And the results that were published indicate a surprising correlation in the blinded versus the first operative period of the active versus control non-stimulated patients, where you see that implantation itself caused a drop in the number of seizures, but thereon there is a substantial difference between the ones that were stimulated as a group and the ones that were not in the blinded period, which had a total of 3 months duration. As you can see, stimulation is not the end-all and be-all if you have this. In 81 subjects, as you see here, you see a median of 56% reduction of the seizures. There were only 6 seizure-free individuals in those, but there were quite a few that had an increase of seizures as a result of the stimulation. So on the whole, a positive result, but there were the ones that really did poorly, not only worse than before implantation. So we have to take this into consideration. More surprisingly, the effects that we're seeing here are also in the period of study that was carried out, in terms of not only neurocognitive, but also in terms of mood and affect disorders, quite discouraging. When the FDA in the United States reviewed this study, they compared the results to the ones of the EO3 and the EO5 trials with the vagal nerve stimulation that preceded this by 15 years. And they came to the conclusion that the responder rate at 1 year and the percent seizure reduction was not significant enough to warrant establishment of this type of treatment in the United States without additional investigations. As a result of this brilliantly designed and executed study, which had significant results, did not have a follow-through in the United States, but it did have my follow-through in Europe, because although this was a North American study, the results were interpreted by the European medicine authorities as convincing enough to allow the use of this stimulator in Europe. And in fact, in a number of European countries, and I don't know whether that's in Greece as well, but in a number of European countries, in our country certainly, there are patients that are being implanted with the anterior nucleus of the thalamus device, and they're being followed in a protocol which is known as the Moore Registry. I will not give you more information on this because it's not the responsive stimulation that I want to talk about. The real topic is the closed-loop intracranial electrical stimulation. The closed-loop intracranial electrical stimulation allows the sampling of intracranially obtained EEG on the basis of indwelling electrodes in the patient. The previous studies did not allow that. They just implanted the electrodes and they activated the stimulator with a particular protocol. This one allows a sampling of the running EEG. It allows online analysis to determine what the analysis algorithm will tell you will be a significant event. We will touch about that later. And it allows the stimulator to give a full authority circuitry control stimulus a counter-stimulus in order to stop ictal propagation or to annihilate the seizure right off. So it also gives you the possibility to read out offline what the intracranial electrical stimulation does. And it also allows you theoretically to do a statistical analysis of successful versus failed efforts to arrest the seizure propagation and possibly to allow reprogramming of the device. So that's the theory behind the closed loop. Now, as opposed to the open loop simulation, the open loop stimulation is a truly intracerebral or extracranial. The vagal nerve stimulator is an open loop stimulator. There is no change in the duty cycle of the firing of the apparatus other than externally modulated by a physician or the patient. It's a fire and forget principle, really. The seizure adjustment, by and large, occurs by a physician in regular outpatient department controls on the basis of seizure calendars of the patient. So the patient tells you, I have more seizures, then you might want to do something about the parameters. The validation of the vagal nerve stimulation is the trials that I've mentioned, and the certification of the vagal nerve stimulators both in the United States, North America, and Europe. And an example of intracranial electrical stimulation is the anterior nucleus of the thalamus, DBS. The validation that I've mentioned is the Santé trial that I've mentioned already, and the certification is obtained only at this time in the free trade association countries and the European Union. So the closed loop is intracranial electrical stimulation. It's only intracranial. You cannot do that extracranially. It's subdural, intracerebral, or both. You can allow the EEG analysis to determine the duty cycle, and you can adjust on the basis of seizure detections. And the example is the responsive neural stimulation. And the validation of this is the RNS Pivotal trial, and the certification has been obtained in the United States. So now we're moving to the comparison of the RNS system, but just briefly to see how an open loop DBS will work. This is the stimulator that is implanted in a chest pocket, and those are the intracerebral electrodes targeting the anterior nucleus and the thalamus with 4 contact leads that you see here and over there. And this is the closed loop RNS system, which implants the device intracranially. So there is a phrased out piece of tissue, of bone tissue, where you can put the stimulator. And this allows the placement of electrodes either in the hippocampus that you see here or subdurally. So there is no contact with the chest cavity or the chest at all, not the chest cavity. There's no wires in the neck, for example. There's less movement possibility to cause problems. So the schematic of the closed loop intracranial electrical stimulation is that you have a stimulus isolator which isolates the signal collection from the stimulus itself. Seizure detection is optically isolated from the patient, meaning that there is no chance that you can short circuit the individual. And you have an electrical stimulator that will trigger a counterstimulus to go in the patient's head. And in this particular case, the stimulator was also activating wires that were implanted in the brain of a perfused animal to carry it, to see whether the stimulation caused a damaging effect to the brain. Now, there's extensive studies on this. I will not touch on that. Gordon and Lesser have published that everything below 50 microcoulomb per centimeter square per phase of administration will not cause any appreciable damage to human tissue. So there is a lot of experimental but also human evidence. And in fact, Penfield's experiments in the OR gave the equivalent of more than 500 microcoulombs per centimeter square per phase if you compare that to what is being done now. So the closed loop intracranial electrical stimulation is current control charge balanced by phasic pulses. The stimulation frequency can be varied from 1 to 333 hertz. The current amplitude is 0.5 to 12 milliamperes. It's a constant current controlled stimulator, and the pulse width of 40 to 1,000 microseconds. This is an implantable device with a neurostimulator power supply and 2 4-contact leads, a strip, and an intracerebral electrode. And the stimulation pick can to fire within any of those contacts, subdural, intracerebral, including the stimulator case itself. This is in terms of the technique, but how does this work in practice? Now, these things have been validated on the basis of intracranial monitoring in patients undergoing acute pre-surgical evaluation in EMUs in North America. And essentially, what you get is a trace like this from the neurostimulator, where you can see some periods of activation that are given here and the effect of the activation on the EEG. This is an enlargement of what you see over here. So there is 3 detection values that are being used: the line length, the half wave, and the area. The line length essentially looks at the length of an EEG change in terms of amplitude from sample to sample, and compares that to the preceding period. The area calculation is the energy which is under the curve of the signal. So if you have, let's say, high amplitude deviation from the zero line and then followed by a decline, you count the area under that curve and you figure that out. You compare that to the tracing before. For example, you can see here high energy discharges. Those are the ones that you see over here compared to the ones before. And the zero crossing is the half wave detection, which is essentially how rapidly does the signal cross the zero line. You have negativity, positivity, negativity, positivity. So those 3 parameters in a mix will determine whether the stimulator will fire or not. Okay, so this is the way it will work. So the pivotal trial that was carried out, analogous to the Santé trial in anterior nucleus of the thalamus stimulator, included 191 patients who essentially followed the same protocol as the anterior nucleus of the thalamus. So back to back, there's a comparison. Essentially the same design with a baseline period, post-operative stimulation, a blinded evaluation period, and open label extension of the study, with a follow-up after 1 year and also a follow-up after 2 years, and that led to a couple of publications that I will deal with later. And essentially the tables that you can see in the literature in neurology in 2011 by the paper of Morel. Again, we see a significant drop in the seizure frequency with respect to the one that occurred prior to the implantation, and then a parallel change in the occurrence of seizures in the sham versus the stimulated in the open label period continuing. On the basis of these results, the FDA audited this device in the United States in February 2013 and approved it for use in November 2013. And as a result of this audit and the immediate period, there was a paper that was published in Epilepsy and Behavior in 2014, where a number of the limitations were delineated. Incidentally, the second author of that paper, Jose Cavazos from Texas, was one on the panel of the FDA that approved the device. The criticism is to what extent is the seizure reduction attributed to the activation of the stimulator due to the immediate seizure aborting or mitigating effects of stimulation, or to longer-term neuromodulating influence on seizure initiation and propagation. The long-term neuromodulating influence we also see in the vagal nerve stimulation studies, where given time, people also have an improvement. This study was carried out with a 1-year end period, and it was extended to a 2-year period, and this is after the 1-year period. What parameter adjustments in detection or stimulation or both would result to more positive outcomes, and which ones will be likely to be of most benefit? The study did not really tell you about that. And the study did not provide EEG data determining the device's seizure sensitivity and specificity. And it did not provide EEG evidence of the effect of stimulation on the rate of seizure occurrence, which is surprising because you would say, okay, so this is a sensing stimulation, so we will have all the EEG signals, so why can't we do these calculations? There is no answer given immediately, because soon after that in Epilepsy, the paper of Heck et al. With a 2-year follow-up appeared, and on the basis of which Osorio in Epilepsy 2014 gave some more critical remarks. And finally, after 2 years, those were answered by Borel in Epilepsy in 2014. The paper that I now allude to was published in March of this year. The same group of investigators that contributed to the first paper in neurology. The results are more extensive, and of course the open label period is much longer. And again, you can see 175 patients completed the study with a 2-year follow-up. You can see that after the drop then the responders rate and the median percent reduction follow hand in hand and improve over the course of time. Those are months after implantation, but that's only the responders. And you can see, in contrast to the anterior nucleus of the thalamus stimulation, that the quality of life did improve, and most of the neurocognitive functions, as well as the affect, also improved in a 2-year follow-up period. What were those patients really? A third had epilepsy surgery already. So those were failed epilepsy surgery candidates. And more than a third had a vagus nerve stimulation before. So you're dealing with a group of back against the wall situations where anything that can help you grab, as Dr. Alexopoulos yesterday said about the treatment of status epilepticus, anything you find will help. There were no differences between the ones that had mesial temporal lobe epilepsy and the ones that had neocortical epilepsy, with 1 or 2 seizure onset zones, and in patients who have been treated with a vagal nerve stimulator, those who were not, and those who had epilepsy surgery or not. That's what the statistical analysis tells you. The mean reduction of seizure frequency is significant in terms of the sham group, and the median percent reduction of seizures was 44% in 1 year, and it increased analogous to other stimulations 2 years post-implant compared to the baseline. So the adverse effects were no worse than the ones reported by other invasive stimulator studies. The stimulation was well tolerated. Only 3 patients left because of problems to study. No significant deterioration in any measures or in moods in the blind period compared to the baseline period, or 1 or 2 years post-implantation. So it seems to be doing what it is for the ones for which it works, what it can for the ones for which it works. So the most common stimulation parameters in the programming of the stimulator was 1.5 to 3 milliamperes with 106 microseconds duration and 100 to 200 milliseconds of a burst with a frequency between 100 and 200 hertz. 200 hertz is the low end of what you use for deep brain stimulation in extrapyramidal disorders. And 100 hertz is really inefficient in the Santé trial studies. The majority of the patients had the stimulator that was activated 600 to 2,000 times a day. But the total current that was given, and that's the main difference with the non-responsive stimulators, was for less than 5 minutes per 24 hours. The vagal nerve stimulator and the deep brain stimulator will be activated throughout the day, okay, at regular intervals. This thing fires 6,000 times a day at most, but only for 5 minutes. But it's impossible for you to have 6,000 seizures a day. I mean, nobody has 6,000 seizures a day. So a lot of this charge is given for nothing, okay? So it's very safe, but not specific in terms of when it's being given. But again, the total current that you give is less. So the criticism that was given, and it was quite brutal, is that the total frequency of seizure occurrence in the RNS reported on the basis of seizure calendars was carried out although ECOG data should have been available. And assessment and optimization of the anti-seizure therapy, including electrographic seizures, was not supplied, only the broad parameters of what worked for the ones that worked. And the timing of the stimulation, the seizure onset, the presence or absence of immediate prolonged carry-over stimulation effects, positive or negative, in mood or other things, and the time elapsed since the delivery of the first treatment were not provided overall. The reply that Morel, who was the author of the first paper in neurology 2 years back, had offered is that it's not a seizure counter. The device is programmed to detect and respond to ECOG patterns. And some of those are electrographic seizures, but most of these are interictal discharges. If the area under the curve of an enormous discharge would activate the stimulator, that could have been on the basis of a single spike, or in terms of a rapid recruiting rhythm. Now, the stored events, and that's the problem, appear to be very limited because the data storage is limited. When the device is externalized and you can have the output in an external computer, you can store much more. But this has a small internal buffer which keeps the events and the amount of current that were given per event, but not much of the EEG around that event. So determining the duration and the extent of seizure spread would require more electrodes covering larger areas of the brain than the 4 leads that you have. They're subdural and intracerebral electrode, and those have a total of 8 leads, and they're placed on the basis of seizure of prior knowledge to the area where the seizures originate and might propagate, but really not to the extent that you have when you have a grid recording or when you have an intracerebral depth recording. And despite of all those limitations, it's safe and effective for the majority of the cases, certainly for the responders. And this is really an American argument. It was approved by the FDA, so don't blame me. Blame the FDA for approving it. And then, of course, the last thing is really the comment of death for everything, that you treat patients, you don't treat seizures. But really, the authors of the paper go beyond the criticism, try to really alleviate it by inappropriate means, in my own opinion. Be it as it may, the RNS system is a responsive cortical stimulator, and it was approved in the United States, as I told you, for adjuvant therapy. Reduces the frequency of seizures in 18-year-old or the patients with partial onset seizures who have done a pre-surgical evaluation, and they have no more than 2 seizure onset zones. We're not talking about people that have what we called multifocal epilepsy in the past. They're refractory to 2 or more anti-epileptic drugs, and currently have frequent and disabling complex partial or secondary generalized seizures. So this is the indication for which this thing is being used in the United States. It's not registered for use in the European Union, though, so we do not have any evidence of this in this part of the world. So, as you can understand, we're talking about a minority of patients, but the ones that have severe epilepsy, severe refractory focal epilepsy with frequently disabling seizures, no candidates for epilepsy surgery, are the ones where surgery has failed. And so that will give you the scope of its applicability. So what we need in designing additional studies, and this behooves us all to consider this, is the period post-implantation. The blinded period should be longer, and the follow-up, that the open-label study, should be even longer. The Santé trial has been stopped after 1 year, and there's no continuation of that in North America. But this thing will continue for another 7 years, so we will have more results in the next 7 years from those 191 implanted patients, at least. We should recognize that there's a transient seizure reduction as a result of implantation, so we should not be surprised if our patients or the stimulator shows that there is an improvement in a short period of time. And we should validate the algorithms and extending the study to intracranial studies with externalized ECOG data, so we see what we're doing. The anterior nucleus of the thalamus study by Andrade showed a very significant drop in the pre-stimulus period. In this particular patient, you see from 125 seizures before they went to 65, this one from 120 seizures to 11, just by only implanting electrodes. So we should, and this is the same for the hippocampal electrode. You see an enormous drop as a result of the implantation. So implantation might do something to the tissue itself. You might do microsurgery by just implanting electrodes if you implant them well. We should take this into consideration. So, is there a window of opportunity in preventing seizure onset? The study that I will mention to you, or the series of studies, are primarily driven by our own experience, where subliminal stimulation of 10 to 20 hertz is being applied to find out what the condition, the excitability of the brain is at that time. And you apply a measure which looks at the phases of the signal to find out whether the external subliminal stimulation will synchronize the phases or change the phase differences between the signals that you get. The results of that study are given in the slide that you see here from a publication in Clinical Neurophysiology in 2005, where you see that this measure increases in the course of time. Those are hours before the occurrence of seizure, stays up when the seizures occur. Those are the red lines that you see here. And after the cluster of seizures is over, they will drop down to the baseline. So you have something here, at least in that particular study, which will show you that you're moving towards having seizures, whether those seizures are caused by medication reduction like you have in the EMU in most cases, or because the cluster is coming irrespective of what the medication level is. Anyway, it tells you that you have an index on what the occurrence of seizures might be in the nomograms that you see before I'll explain the paper. So although the precise moment of the ictal transition from the intraictal to what we consider intraictal to the ictal period is unpredictable, you have an estimation of the probability of occurrence of an epileptic seizure on the basis of these measures. And they may be used to guide interventions with the aim of modifying local tissue excitability. Now that you know that you're moving towards a seizure way in advance, you might have a chance to do something else and tell the patient to go lie down and wait patiently. You might try to avoid seizure occurrence. So it gives you an extra emphasis on neuromodulation. And that would be this. An algorithm will calculate not whether you have an ictal event or not, but whether you have a chance of seizure occurrence, okay, on the basis of the stimulation. The differences in base will be compared to the intraictal and the earlier recorded EEG signal. That was something similar to a poster that we saw yesterday. And there should be a threshold for which you will have to administer intracranial electrical stimulation. Up to now, this looks very similar to what the responsive neurostimulator does. However, the next thing would be to try to get the system back in the intraictal condition. If by means of a particular stimulating paradigm, you move away from the threshold of occurrence of seizures, then you stop there. If you do not, then you fire like the responsive neurostimulator does in an effort to abort the seizure. So that gives you an extra level of safety. It's a two-stage rocket, let's put it like that, instead of a one-stage rocket. So this would be the scheme that you have to use. And of course, what you need is, although the device is internalized, okay, there should be, through an external control, there should be some way of recording the EEG continuously. So that would obviate the need of your stimulator transmitting the data on its own. It will transmit the data through a device which will charge the battery of the stimulator by induction. So this thing will be charging and also recording the signal as well. And again, the paper or the poster that we saw yesterday might be an indication of things to come. So in a nutshell, I hope that I was able to cover those topics for you. I realize that this is a rather technical issue, and most of you will have no experience with devices of this nature. Of course, VNS is quite commonplace in Greece, and some of you might have actual hands-on experience with this, but I am almost definite that none of you have experience with the deep brain stimulator except for the experimental disorders that I have mentioned. Although then the material is rather germane, it is also rather difficult for you as an audience, and I apologize again for delivering it in English. I would not be able to do that in Greek myself. And I thank you for your attention.